Shelby, why don't you do the introduction?
Okay, thank you, Raju. Good morning, everyone. Thank you so much for joining this Sunday morning. It's our 41st session. And we are very lucky to have one of our stellar GI pathologists from MD Anderson join us, Dr. Dayali Chatterjee. You see her here on the panel. Just a few words about her, because I'm a huge fan of hers. She did her GI pathology fellowship training with us and in our institution, we have a weekly GI pathology case conference. And our GI pathology fellow is the one who runs the conference with under the supervision of a GI pathologist. And so it's a one-year fellowship, and she did a fantastic job. She is currently assistant professor at the Department of Pathology. She did her medical school at Calcutta Medical College, pathology residency at Baylor College of Medicine. As I said, she did her GI pathology fellowship at MD Anderson. Unfortunately, she left us when she finished her GI pathology fellowship and went to Washington University, where she was associate program director for the fellowship, resident advisor, and staff pathologist at Barnes Jewish Hospital, 2 locations. Very important, she was awarded Faculty Teacher of the Year at Wash U. She has 62 peer-reviewed publications and 4 book chapters. She is passionate about education, and so we've always had pathology within this conference on Sunday morning. We had some questions specifically about specimen processing last week, and so we've invited her to join this morning, and hopefully she'll be able to join other mornings as well. Dayali, good morning, and thank you so much.
Good morning, and thank you for the wonderful introduction. I'm really happy and honored to join this session, and I'll try my best to attend every session. Although, being a Sunday, I cannot promise for all, but I'll try my best.
All right, thank you, Dayali. Really appreciate your help. Good morning.
Thank you, Dr. Raju.
Good morning. And I just want to say hi to my good friend, Syed. Welcome, Syed. All right.
Thank you. Pleasure.
So what we're going to do is, first of all, I want to thank my mentor, John Stoline, and I want to acknowledge the support of Mr. Charles Butt and the HEB Grant, Angela Dio, and my institution. So if any one of you want to receive CME from MD Anderson, you can get it. If you want to know how to set it up, actually, I have this YouTube link here, and you can go to my YouTube channel, where I actually created a video about how to set up your CME so that you can get your CME from MD Anderson. All right, so this is an interesting problem. This is a woman in her 60s, late 60s, in good health, except for hyperlipidemia and aspirin, no major medical problems. I took care of her husband, and they decided to come here after having had found a polyp in her colon. She underwent her colonoscopy in an outside facility about 7 hours away from our center. And the findings include a tortuous redundant colon, somewhat fixed in the left lower quadrant, and a flat, granular, benign appearing sessile 2.5 centimeter polyp. Biopsied and pathology revealed sessile serrated adenoma. I basically copied and pasted whatever I saw in the endoscopy report. She was later seen by a surgeon who recommended a right hemicolectomy, and she decided to have a second opinion. Our family history is positive for colon cancer. Mother and sister dealt with colon cancer. And here are the images. As you can see, The left, I may want to see the images here. And why don't I ask Zubair, say for example, if you see this endoscopy report from outside, why don't you comment on what you see, and then how do you deal with this?
So I see a sessile polyp, although I think the maybe the preparation of the colon was not that good, but I see definitely a mucus cap. The lesion is slightly elevated. The margins are slightly irregular, and it looks like to be large, like lesions about more than like 2 centimeter or about 2.5.
Okay. Why don't I ask Sylvia to comment on what you see, and how do you go about dealing with this one?
I think, well, I very much agree with the description by the previous.
Okay, all right.
Several characteristics compatible for sessile serrated adenoma. It is pale, it has a mucus cap, it is located in the proximal colon, and we know that these lesions are amenable for endoscopic resection, so I would do EMR.
Right. So a couple of things I would like to comment for the sake of fellows. One thing is you want to make sure that you get into the habit of clearing off all the bubbles before you take pictures. And by doing that, you are actually sharing that you are taking precautions of clearing the bubbles, because you can miss polyps that are hiding beneath those bubbles. So a good habit to do that. And the best way to do that is to flush simethicone through the biopsy port rather than putting simethicone in the water jet. That's one thing to keep in mind. And the other thing that is I've been doing of late is I tell all my patients to chew Gas-X. Gas-X is simethicone, and I tell them to chew after they take their first dose of the prep, and after the second dose of the prep 6 hours before. And with that instruction, I see less and less bubbles that I have to wash and clear them. So something to keep in mind.
Dr. Raju, if I may ask a question.
Please.
I don't particularly see a good view of the cecum. It could have been because of the redundant left colon, but looks like maybe the first picture is of the cecum, but you really don't see, you see the proximal ascending colon, but document-wise.
Right. You're right.
Pouch.
Right. I think, Saeed, you made a good point. Another point to keep in mind is for the sake of fellows to take extensive, you take a lot of pictures to document cecum. And the best way to document cecum, to say that you reached the cecum, is to include a picture of the terminal ileum with villi. Nobody will argue with that when you say I have reached the cecum and I've entered into the TI. But otherwise, you want to take pictures of the appendix orifice and the cecal base, and also the ileocecal valve and the terminal ileum. And this is something we don't see. Probably I'm wondering whether the endoscopist, when he put in the report that he struggled through the left colon, maybe he was slipping in and out, and he felt that he reached the cecum, but he didn't have time to take a picture and document it. That's possible. So, but otherwise, when somebody is reviewing your record, the only way to make them convinced that you did reach the cecum is to take multiple images. And I want to ask Selvi to comment. Actually, Selvi and Bill actually reviewed our own records at one time to see based on the photographs. Do you want to comment on that? Long time back.
Yes, it was a long time back. So I think just a couple of comments. I think it is important to clean, and from a medical legal standpoint, it's important to do photo documentation of the colon landmarks that you just described, Raju. It's also important, and I just listened to a webinar from Doug Rex on the ACG website, where he talked about how important it was when you do photo documentation of the colon, apart from the landmarks, it's also important to clean, because if this endoscopist said that the prep was adequate for polyps, and then the pictures all show these bubbles where it hasn't been cleaned, those pictures should not be included. So if you say the prep was adequate for polyp detection, your picture should show a prep that is adequate for polyp detection, because on potentially on, from a medical legal standpoint, the lawyer could say, look at all these bubbles. How many polyps could you have missed under there? Did you wash it? If you didn't wash it, if you washed it, there's no pictures of it, that type of thing. So for the project, the research that that you're discussing, actually, you were our blinded expert that was going to look and see if what they call, I remember the project, Raju, what the endoscopist in a blinded fashion, you didn't know who the endoscopist was, but if they actually took the pictures of what they called cecum, if it was clear to Bill and myself that it was cecum, then we included it. And if it wasn't, then you were the expert that was going to reconcile it. So tell us your thoughts on that.
I think one of the things that is important is to take at least 3 to 4 or 5 pictures to document that you are in the cecum. And sometimes when you take a picture very close to the appendiceal orifice, you can take a similar picture from a diverticulum and make it look like an appendiceal orifice, right? So it's important to do that. And I never feel comfortable thinking about the cecum, that I reached the cecum until I actually saw a villi of the TI or villi of the close to the ileocecal valve. I want to convince myself. I've actually made mistakes where somebody has had a cholecystectomy and there's a lot of scar tissue in the right upper quadrant, and you try to, you can actually imagine yourself that you reached the cecum, and everybody around you could also be convinced that you reached the cecum. And one way to get out of that problem is to say to yourself, okay, I won't say it is cecum until I see the valve or until I see the terminal ileum. So that's something to keep in mind.
Raju, back to this case, did they say what the issue was, why they didn't resect it? Why they didn't remove that polyp and just biopsy?
I don't know. I think basically we're gathering, reflecting on my own experience doing this case, I can say that the endoscopist must have had a tough time maintaining a stable position. And you will see in this video that I actually slipped back. And I didn't include a lot of that video of slipping back and trying to maintain the stable position. I did struggle to maintain a stable position. And maybe that's one of the reasons that the endoscopist felt that, okay, this could be resected, but I'm not in a stable position. And if you're not in a stable position, that is a polyp that you should not resect, because if you resect, you're probably going to not resect completely. And the second one is if you resect and end up with either bleeding or perforation, you may not be able to manage that. Suddenly you're converting an elective case into an emergency surgery. So that's my impression based on doing this lady's case, because I also had trouble maintaining a stable position initially. I had to struggle quite a bit to get to that stable position. And once the scope was in a stable position, then the rest of the steps were relatively straightforward.
May I ask a question, Professor Raju?
Please.
I was wondering whether you can give us some more detail about the sedation of the patient and the type of endoscope you have used, the type of colonoscope you have used in this procedure.
Right. So in this one, once I read the report and that she had a difficult exam, I picked up a PD colonoscope for her. And for all my EMRs, I use general anesthesia, routinely as part of a practice. Part of the reason I changed, it's about 5 years or 6 years back, we shifted everything to general anesthesia, partly because I was noticing that in some patients, the movement of the right colon and the transverse colon as the procedure went on was quite a bit. And it interfered with the quality of the resection. So I said, okay, if I ask the anesthesiologist to paralyze and keep a low tidal volume, I can actually have a stable operating field for better resection. So
Thank
that's what I
you.
did.
Thank you.
Right. So here is the polyp. It looks a little bit different from what you saw there after washing. And maybe Sriram could comment on this. So you can see here, right, I kept slipping back, for the sake of our session, I actually eliminated quite a bit of video where I struggled to maintain that position, but I just wanted to show you a little bit. Sriram?
What was the question, sir? I missed that part.
No,
Are you
just
talking about
comment on-
maintaining?
Yeah, maintaining and then comment on the polyp. So
Yeah, I was just trying to type a few comments on the suboptimal prep. Just one more question. Is the session for the regular session, or are we waiting for pathologists to comment, make a presentation or something so that I can appropriately talk about it?
no, pathologist has slides, images once we do the resection of the polyp, and
Okay.
then they all will comment on that. Yeah.
Yeah, two, three other comments. Whenever a patient has a suboptimal prep, I'm just continuing the conversation of the previous segment. Suboptimal prep and a larger polyp, whether we deal with it or we refer to somebody else. Two other considerations come to my mind. One is that if the prep is suboptimal, there is already a polyp that needs to be managed. What more other polyps that am I missing, if there are any, under this suboptimal prep? And suppose such a patient is referred to you, the question will remain that the patient is referred to you for management of this big polyp. But at the same time, what is not mentioned, what is implied is also that you will take care of the rest of the polyps if there are any, which means that the screening of the rest of the colon falls on the second endoscopist. From forget about medical legal or any other point of view, we are all if we are keeping the patient and patient's care at the center of all these conversations. Patient comes to the first endoscopist for screening colonoscopy. We found one big polyp, so we need to screen the rest of the colon. But patient is going to the second endoscopist for the care because of the larger polyp. And during that large polyp resection, your focus is on that one. So the rest of the colon screening may or may not happen at the time. So that is something that needs to be kept at the back of the mind all the time. So because we may successfully manage this first polyp, but we might still be not doing a good job of screening the rest of the colon if we are not keeping that as a focus and at our back of our minds. Which means that a third endoscopy for the sake of, say, piecemeal polypectomy, for check endoscopy to see the adequacy of resection, that will be the time to make sure that nothing else is remaining. Otherwise, we end up either ignoring one of the important factors or spend too much time in doing the rest of the screening and find some other polyps, and then the major polyp takes more time. So balancing of time becomes an issue, But while balancing of time is our problem, clean colon without any more further polyps is the patient's goal. So those things have to be aligned, and that is something that I'm always concerned about when these kind of suboptimal preps come. The second comment I have in that context is, when there is a suboptimal prep, like in this patient's, the way it is appearing, bubbles, these can be cleaned with copious amounts of lavage if we can do. Whereas there are other situations where the mucus is so adherent that you cannot clean it properly. That requires truly a second prep, second 2-day prep, and then do procedure again. So that is what makes me decide whether I would like to clean and look for other polyps, or I would just say that this needs to be done at a second time. No matter what I do, what approach I do, it is important to include it in the report. What did we do for the rest of the colon? Have we examined or have we not examined? That will help the next endoscopist, the implied requirement for screening the rest of the colon. Otherwise, each of us who does endoscopy will fulfill our primary goals of dealing with it and then forget rest of the things. And that will be to no advantage to the patient, although patient is saved from the main polyp. Sorry.
No,
So
no,
now,
actually,
coming to this polyp.
no, okay, go ahead.
No, go ahead, finish the comment so that we can go to the polyp.
Yeah. So I first of all, I'm glad that you bring this to a point. And this is what I do when I see patients. I tell them that, okay, your physician asked me to take care of this polyp, and our goal for this session is to remove this polyp. And I also tell them that if I see other polyps, I'm not going to address them because I don't want to get caught up in addressing these small polyps, which might make my large polyp resection technically challenging because I put in more air, or you become, you develop other issues. So I tell them that I'm going to deal with this polyp. Usually most of these polyps that are sent are usually on the right side. And once you resect and you take it out with a net or something, you can't see. And the second one is once you resect and close, you want to have those clips not detached because of a lot of air distension. So I tell them that, okay, let's take care of this polyp, and I bring you back at 6 months, and because I want to make sure that the scar is clean and there's no recurrence. At that time, I will examine the rest of the colon as if I'm examining for the first time. If there are polyps that we see, we will take care of them. And I tell them that, okay, I want to make sure that I send you back to your referring physician so that they start from scratch. That means you have a clean colon, I clean up all your polyps. That's the process that I adapt. From a patient's point of view, there is an advantage. The patient is going, and for the referring physician, the advantage is they're starting from scratch as if somebody has had complete clearance of all the polyps. From an endoscopist point of view, like say, for example, if you have a large EMR practice, these patients are going to take your next 2 slots that could be used for an EMR of another patient. It's a balance, where do you find that balance? I think it all depends upon your own personal philosophy. So I tell them that my goal is to take care of this polyp and clear your polyps, as the ultimate goal is to prevent colon cancer. That is, make sure that we do it right, even if it's for one patient. So that's what I do. I think
and in continuation of Dr. Salve's point about the reporting, right, and images, there are 3 factors that need to be aligned in all the endoscopy reports. One is because some of it, 2 of these are quality measures that we are expected to. These are hard stops on the reports where we need to, we are forced to, or we are mandated to comment. One is the quality of bowel prep, and second is the end of the report, repeat colonoscopy when it is indicated. These 2 are mandated to be entered into the report. Now, I think it is important for all of us to keep in mind to align what we say about the adequacy of preparation, what we document and what we do in the body of the report, and what we choose as a repeat procedure when it is indicated in the recommendations report. All three have to be aligned. Otherwise, any mismatch is a potential for missing things beyond medical legal issues.
Okay, that's good. So
Okay.
let's.
So polyp itself, it looks like a, I don't know if you have an NBI pictures, but it does look like a flat polyp, probably a ulcerated adenoma. I would like to see the other side of the fold to be able to judge the extent, whether it is spreading beyond that fold or it is just on the fold. And it looks like something that can be removed by EMR. It looks about to probably 18 to 20 millimeters in size, and there's some mucus stuck on the opposite side of this polyp. Whether that is also another small polyp or not, that can be decided once this is taken care of. Of course, injection, saline injection, and if possible, one piece resection.
Oh, thank you. I want you guys to look at these clips here, and I want to come to that point because I wanted to focus on this polyp, and then we'll talk about it towards the end of the session. So we decided to do the injection, and we used basically saline with a little bit of methylene blue. I did not add any epinephrine. As you can see here, I went forwards and then started injection on the cecal side of the polyp. And you can see my endoscopy assistant is basically slowly injecting, tap, 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 right? And as we're injecting, we're slowly bringing the needle back to give ourselves space. And this was about 3.5 ml of saline injection. It's not a lot of injection, but actually if you get it right into the plane, you would get a good sustained lift. And I feel that saline actually works well for me because it gives me the feeling of tackling a very softer cushion, and that allows me to resect much more easily. My snares tend not to slip when I have saline. And as you can see here, there is a scarring here. The scarring is from the previous biopsy. So when I started doing EMR, I used to inject on the anal side, whatever is closest. And then I used to create mucosal blebs. And the mucosal blebs make it very hard for resection. So as I started gaining experience, one thing I started doing is look at the scar and stay away from the scar with my first injection so that I could get a good lift. So something to keep in mind. If somebody has taken biopsies, you will find most of the time they take biopsies that is closest to them, that is towards the anal side of the lesion. So you go to the cecal side and start injecting. As long as you change the direction of the needle, you can get a good lift like we achieved here. So next is, here is the EMR. We used a 15 millimeter snare, and this is a totally unedited video from the beginning to the end of the resection. And we used a stiff snare, as you can see, braided snare. Although Olympus has both a cold come hot snare, for EMR, I prefer just a stiff braided snare because it tends to be stable, a little bit stiffer, and be able to, even if you press it down, it's not going to flip. And as you can see, this is on the top of the fold. And as I'm trying to resect en bloc, what I decided was I was a little bit concerned because top of the fold resections, if you don't maintain your angle parallel to the top of the fold, you can cut the muscle at an angle, and that could lead to perforation. So one of the causes for perforation during EMR is resecting a polyp on top of a fold and extending on either side. As you can see here, I closed it, but then I slowly relax a little bit, relax a little bit, relax a little bit for the underlying tissue to fall back, and then close again. That technique actually saves you from deep resection. So that is something important to keep in mind. As long as your resection is in the submucosa and doesn't go into the muscle or involve the muscle, you'll have less issues with delayed post-polypectomy syndrome or perforation. So something to just keep in mind. And I will take you to the next step. So let me ask Zubair to comment on where is the level of the resection?
I think it's just above the submucosa.
Yeah, it is in the submucosa. Actually, anyone who's interested, they should read a beautiful paper by Michael Burke published in Gut, where they actually comment about depth of resection. If you see nice blue connective tissue, then you know that it's submucosa. Muscle is white. If you see white bands or damage to the muscle, you should certainly close defects that have damage to the muscle, either superficial or deep. If you're one of those who don't believe in the benefits of clips or worried about the cost of clips, and if you say, hey, which one can I get away by not putting clips on defects? That is when you see a nice superficial submucosa. But at the same time, you have to keep in mind, although you see superficial submucosa, the current damage could go deep. And you may be fooled by looking at a superficial submucosa, thinking that the damage is limited to that area. If you have closed the snare very slowly and had a lot of duration of current application. So something to keep in mind, right? At the end of the day, the depth of injury depends upon the total amount of energy that is delivered. So I did have one delayed perforation, and based on that experience, I tried to cut fast. And in the process of cutting fast, you may end up with bleeding, which is much easier to control. So here we basically used forced APC, 0.8 liters, 35 watts. That's what I normally do. Although the cut looked like en bloc, I always blade the edge so as to cut down the risk of recurrence. And Roy and myself, we pulled our data of sessile serrated adenomas and published that even large resections, 20 millimeters plus, you can have very low recurrence rate if you follow the protocol of ablating the edges. So we decided to close the defect. I truly believe that if you close it right, you do cut down the risk of delayed complications. And here we decided, as you can see here from the first clip application, you don't see the lower blade and with the cap and not seeing the lower blade when we first applied, you can actually push the edges together and apply a deep closure. Most important thing is when you apply clips, it's not clip application. It's a deep approximation of the edges because all these clips can go deep and include the muscle into your closure. So something to keep in mind. The other thing is, you will notice as I'm putting this clip, I noticed a small polyp on the proximal side of the resection. And when we come to that, I will actually point it out. And whenever you see any small island around that resection base, it is best to take it out during the same resection so that down the road, when you're examining the scar tends to pull that adjacent island into the scar tissue and make you feel that you actually indeed had a recurrence, which was not a recurrence, but a polyp that was sitting by the side of the original polyp. So something to keep in mind to clear off any polyp that you see at the edge of the resection. So you can see here, I'm going to show you here, right? Here, there's a small polyp here, right? And we felt that actually two small polyps around that area. We decided that we just remove that now rather than wait because if it comes into the scar tissue later on, you wouldn't know whether it is a local recurrence or whether it is a polyp that you overlooked. Okay. So any comments? One advantage you can see in this case is your cap is actually pushing your clips down and make an area that is a little bit difficult to access, easier to access. And as you can see, that's actually one of the big advantages of a cap. So you can see the cap, you have the cap, you have the clips, and the cap is pressing on those clips to bring that area of interest towards you. So what we did was we decided that we're going to put a tattoo, and I wanted to show you a technique for the sake of fellows or trainees. So we create a saline bleb first. And once you know that you have entered into the submucosa, then you fill that with a spot or carbon particles so that you have a bleb in the submucosal plane rather than injecting outside. So I want to take you through this technique with some illustration. So this is what I do. I have a needle and I've used the saline. I tell my assistant to purge the needle with saline. And once I purge the needle with saline and you flush the needle, then what I do is I take the carbon spot here, and then I ask them to inject until it comes to the biopsy port. That's where I ask them to stop. So that means I have still about a cc of fluid or more in my needle. And then I create the saline bleb. And then as I inject more, I create I fill the saline bleb with tattoo. So this actually allows you to create a clean submucosal bleb and tattoo. So we decided I wanted to share that because it's important to do this. Go ahead.
Professor Raju, I was wondering in this specific case, what was the reason to place tattoo? Because the lesion was removed en bloc It was a complete resection. And I was wondering what was the reason to place the two. The reason was not suspect for malignancy. So
One of the things is whenever I'm resecting polyps, I got into the habit of putting a tattoo so that when I go back and check, I can at least reassure them that it is a complete clean resection. That's one of the reasons. I think you do have a point, is there a need for putting a tattoo? I think, yeah,
I very much agree. This
Yeah.
is practice dependent. I mean, it
Right.
can vary, but in
Right.
our experience, this would be at least these three criteria would be the indications for placing a tattoo in this case. If the lesion was not completely removed, or if it's located on a difficult to access place, that would be also a reason, or if it is suspect for malignancy, or in case of piecemeal resection, which we assume it's highly associated with incomplete resection.
Yeah, you do have a good point there. I think I agree with that.
Okay.
Yeah.
Thank you.
Raju,
Yeah.
for some of these SSAs, it's usually they're pretty soft lesions generally, and they can be suctioned into the scope. Of course, it could get fragmented, and so that's always a possibility. But again, we know that it's an SSA. In the context of this case, this patient had a very kind of difficult left colon to navigate through. So I'm wondering if you tried to just suction the polyp, or you always wanted to do the Rothnet for complete removal and then you would go back in again.
So if you actually, I'm glad that you brought it up. A polyp like this, if I used an adult scope, I try to suction and come out. Usually it comes through the channel. The second one is when you use a pediatric scope, they tend to be very difficult to suction. You get stuck there. I also want to make it a point. What I do is probably not, part of a routine practice. If I have multiple serrated polyps that I'm cutting, right? Sometimes you see patients with serrated polyposis where you end up cutting a bunch of polyps. And in those cases, if I'm using an adult scope and I try to suction it and I cannot suction the polyp, and then I have a bunch more polyps to cut, right? And I don't want to come back with a net and then go back in. In that case, if I'm confident that this is a serrated adenoma with no dysplastic focus, because you can figure out whether there's a dysplastic focus in a serrated adenoma based on the appearance, if there's nodular appearance or whatever. Then I use my snare to actually cut the polyp, cold cut the polyp, the resected polyp into pieces, 2 pieces, and then suction those 2 pieces, and then move on with cutting more polyps. That's what sometimes I do to just take care of the patient rather than making it a prolonged procedure and a lot more stress on the endoscopist or yourself. So let me summarize here. I think it's a 15 millimeter polyp. We use saline and methylene blue. We use a snare, Endocut Q313. We used APC, and then we closed and we put a tattoo. And I asked you to focus on some clips at the beginning of the procedure.
Yes.
And as I was actually coming out of the cecum, I did not put the cecum images here. Just above the ileocecal valve, I found an island of small polyps, as you can see here. And these about 4 or 5 or maybe 6 polyps that I removed, as you can see here at the bottom. And they all turned out to be tubular adenomas. And for the sake of Zubair, who's attending, I wanted to get into the habit of documenting in such a way that whoever reads your report can make it out. You can say multiple cold biopsy polypectomy, multiple small islands separated, and then these are the images for people to look at it. So it tells the story and saves you the time. And the second thing is, every time you do a resection, big resection, this is not a big resection, but every time you do a resection for somebody who's referred to you, a patient, it's important to not only document for the sake of clear documentation, you should take it upon yourself to use that as an education. Your report should help educate others. So that's why you want to include a lot of images that tell a complete story. So this patient went back to her home state, and she did well. I called her about 7 days later, and she had no adverse events. So why don't I give the stage to Dayali? Dayali, you want to take it from here?
Sure. So, okay, your 15 millimeter became 12 millimeter because probably a formalin fixation and some tissue shrinkage that always happens. And so, yeah, so the micro picture, I mean, so this specimen was received in a single piece, and we serially sectioned into 3 pieces. And then, the specimen is inked, as you can see, but what we actually identify as true margin is identifying the cautery that we can see at the base, and then finally at the lateral margin here. So the tissue is folded. If it is a big piece of tissue, and I mean, always the mucosal pieces will get folded, right? I mean, so unless you pin it on a cork board, but usually you would do it for an ESD, not for an EMR. And so it gets a little folded. And if there was an invasive tumor here, it becomes a little hard to assess for the margins. So for a bigger piece, I mean, it would be good for pathology assessment to pin the tissue. But this was great. I mean, so we can look at the lateral margins and all the cautery at the base and the polyp features just at the surface. So there's no invasion, nothing. So when we go, and so yeah. So any questions so far?
Oh, that's good. That's good.
Okay. All right. So we can go to the higher power, maybe the next.
Yes.
Yeah. So these were the 3 fragments, the 3 slices that we made, and all of them had clear margins. The polyp features are right here, very far from the lateral margins. And here we see some on low power magnification, some irregular glands, which are different looking from here. So we can go to the next image. Yeah, so normally colonic glands on cross-section have a rounded cross-section like this. And so these have star-shaped lumen, that's why we call serrated. But when the serrations reach deeper to the muscularis mucosae, which is down below, and so, then you, so that's the defining criteria for sessile-serrated lesion. So WHO since 2019 is calling this as sessile-serrated lesion. Some pathologists have adopted, but others are still using the term sessile-serrated adenoma/polyp. So yeah, I mean, so if the serrations were confined only to the surface, that would have been a hyperplastic polyp. There's no nuclear atypia, so there's really no conventional adenoma component. I think because using the term adenoma makes it a little confusing, but it has been so many years that everyone now knows what it is. So this was not a good time to change the nomenclature, probably. Not many people are happy about it. But yeah, so these are the features of sessile-serrated.
May I ask a question?
Sure.
Thank you very much for this thorough characterization. I'm not a pathologist, so please excuse me if I don't ask the most accurate things. as far as I know, so this would be a sessile serrated adenoma without dysplasia. Am I right?
Right, absolutely.
And for labeling as sessile serrated adenoma, we need, besides the stellar, the star-like aspect of the crypt opening, we need to see the boot-like appearance, the dilated basis of the crypts. Is this obligatory sign for sessile serrated adenoma or not? You have nicely demonstrated that the crypts, the star-like appearance of the crypt opening can be recognized until the muscularis mucosa. But I haven't seen the boot-like, the dilated appearance of the crypt basis. Is this obligatory sign or not?
Sure. So what is obligatory is to see the serrations going to the base of the muscularis mucosae, and then they can morphologically, have shapes which resemble boot or T or L. So, they have called it an L-shaped gland or T-shaped or boot-shaped. Now that's your imagination. Essentially, what it means is that serration has to go deep and touch the muscularis mucosae, and it's a little broadened at the base too, because the proliferative center, for normal glands is right at the base. Here what happens is proliferation moves to the side. And so when the proliferative center is at the side of the glands, it actually goes upwards and downwards, and then the downward growth is stopped by the muscularis mucosae, and therefore the gland starts broadening. So I think the boot shape or T shape or L shape are descriptions of what is essentially happening is shifting of the proliferation center of the glands from the absolute base to the sides of the glands.
Thanks a lot. Very clear explanation. Thank you.
Thank you.
Thank you so much, Dayali. Really appreciate it.
Sure.
A beautiful description. And I'm glad that I've learned that, the way you described the proliferative zone, pushing it down, and then the gland shape changing. I think it's learned something new. All right.
Thank you.
So why don't I just leave it here and open for discussion, and any comments on the case?
I have a very short comment, if possible, Professor Raju.
Please.
This is a very nice illustration of a sessile serrated adenoma, which can be commonly found at colonoscopy. As we know, sessile serrated adenomas are most often sporadic, but they can be part of the serrated polyposis syndrome. And because in this case, the bowel preparation was suboptimal and there were some lesions left in place, this will raise the question, is this definitely not a serrated polyposis syndrome? As far as I could figure out, the patient, this case does not fulfill the criteria of serrated polyposis syndrome. But maybe bowel preparation also confounds our diagnosis. So next colonoscopy will be for me colonoscopy with chromoendoscopy. I would use a contrast agent to be able to phenotype the colon to make sure this case is not a serrated polyposis syndrome. And I recall in the beginning you told us that the patient had 2 first-degree relatives, mother and sister with colorectal cancer, but I didn't hear what age. So there might be some familial component in this case. So I would pay attention to this aspect in the future.
Right. I think it's a very important point that you made, to not forget about the family history and pursue that. One of the things we wanted to do is when she comes back next time, to get her seen by the genetics group and Salvi to define her problem further.
Thank you.
Yeah, one problem that I'm actually facing is not problem I face. When you can have an excellent colon prep, like a Boston Bowel Prep scale of 9 and no bubbles. And you have the latest series of scopes with magnification or whatever. Not magnification, near focus function and others. When I try to examine them, and as you examine them with your scope close to the wall, not in the center of the lumen, but in a circular motion close to the wall with a cap-fitted scope, the number of times I find something additional when I do a chromoendoscopy is very small. And that's why, you know, I try to do a good exam with a white light and take time and examine. And one of the problems that I face with chromo is the moment I put chromo or dye, the endoscope light is cut off. You know, for some reason it gets darker. And the pools of puddle are again harder to see. So how do you normally do your chromo?
I'm very glad that you brought this point again into discussion. I think we have discussed it in the past as well. And I would like to mention again, we have this data in patients with Lynch syndrome in a Spanish randomized controlled trial using either high definition white light endoscopy versus pancolonic chromoendoscopy with indigo carmine. And it seems that in experienced endoscopists, in those who had performed such kind of difficult procedures for many years, the additional value of dye-based chromoendoscopy is very low. Actually, there was not significant difference, but there was a significant difference in finding flat lesions. So that was the difference they found in that study. And I think chromoendoscopy, if the bowel is very well prepared, because as you mentioned, this is crucial. Without an optimal bowel preparation, with a BBPS 8 or 9, ideally 9, the additional value of indigo carmine dye-based chromoendoscopy is 0. So I have used during my experience in the very beginning a lot of pancolonic dye-based chromoendoscopy, and I think that I would recommend that to every endoscopist in the beginning of his or her career to create better mental representations of the flat adenomas, to understand how they grow and how to remove them completely, how to inject, to visualize them better, to remove them better. It comes a moment when we become confident we may not need to use dye-based chromoendoscopy routinely. We use it selectively for large LSTs, which are with border which are not very clear, or in case of very large serrated polyps with indistinctive borders. And probably in the end, high definition and white light endoscopy in combination with digital chromoendoscopy have the same value. But it's a learning curve. That was my the point I wanted to make. It's a learning curve.
Yeah. All right. Thank you. Thank you. Thank you so much. All right.
In my
Any
experience,
last minute comments, Selvi?
No, Raju, I think this was an excellent case, and thank you for presenting it, and thank you to Dayali for participating. I think it really added an extra layer of information and education.
Joseph? Sriram?
I think, sir, very good discussion, excellent pathology conversation. Just one point to add. My pet peeve is about while doing NBI to make the movements slow, because to give time for the electronics, the digital chromoendoscopy to happen, to be able to for the images to stabilize. Otherwise, then the lighting is likely to improve a little bit. If we are doing the scope movement constantly, the digital adjustments will take time. So all you see is darkness. So that is something to keep in mind, to have a steady hand and a slow movement when we are interpreting NBI images.
Oh, thank you, Sriram. Syed.
Excellent session. I can only say, as a practicing gastroenterologist, sometimes not that they may not do it, but in a very active practice, especially this gastroenterologist who might have been 7 hours away, it's difficult. But I think from a patient perspective, they should give the option to the patient of both sending to a tertiary care center like yours, or surgery, rather than just sending him to the surgery. That's the only comment I can say from a practicing gastroenterologist perspective. Excellent session. I wish I knew about this. I'm going to be a regular Sunday listener.
Thank you, sir. Thank you. All
Gratitude. Sorry, I forgot. I realized I was not. I was muted the whole time. No, I agree with all the notions so far, especially as in pertaining to the earlier comments about the documentation and what the focus of the endoscopy is. If there's a chance that if, for instance, if I'm doing an EMR and I do have an intention to go back to rescreen later on, I'll still mention the bowel prep quality, but I'll further put a qualifier in the report about how maybe I did a cursory review of the left colon and with the intention that in my report that I'm going to bring the patient back within X amount of months to re-examine for polyp clearance.
All right. I want to thank everybody. Hope you have a good Sunday. Dayali, thank you so much for joining us. Selvi, thank you. Sylvia, thank you. Joseph,
Thanks a lot.
thank you.
Great
Sriram,
session.
thank you. Syed, thank you. Dr. Graham, thank you so much.
Thank you.